Hi, my name is Christina Hanson, and I am a nurse practitioner working at South Denver Gastroenterology here in Denver, Colorado. And I wanted to come on today and just talk about some myth dispelling, if you will, dispelling of myths around liver health, and in particular around how we are identifying patients with fatty liver in today's day and age. So we know that there's been a change in the nomenclature of fatty liver from NAFLD or NASH to MASLD or MASH, Metabolic Dysfunction Associated Steatotic Liver Disease, which really does fit the description better of what fatty liver is. It's based on metabolic risk factors and the high risk that we have of having fatty liver with these cardiometabolic risk factors, rather than it being alcohol versus non-alcohol. And so that's one of the prominent messages that I really want to see expressed, especially to our primary care cohort and our endocrinologists, because it changes the way that we look at identifying patients with fatty liver. Instead of waiting for lab work to show elevation in liver tests or incidental findings of steatosis on imaging, such as an ultrasound, what we really need to be looking at is those patients at risk for fatty liver, and notably those with obesity or type 2 diabetes. So in patients with obesity or diabetes, there's a high percentage of patients that will also have coexisting fatty liver. And in obesity, upwards of 70-80%. In morbid obesity, over 90% of patients can have coexisting fatty liver. And we know that in type 2 diabetes, over 50% of patients can have fatty liver, coexisting fatty liver. So I want there to be a shift in the way that we're identifying patients, looking at those cardiometabolic risk factors, including hypertension, dyslipidemia, and thinking that this individual should be screened for fatty liver with some non-invasive testing, rather again than waiting for elevation of liver tests or imaging findings suggestive of steatosis. And certainly for our primary care cohort and endocrinology partners, using that non-invasive test of FIB4 is really what our guidelines are recommending. That includes our guidelines here in the United States as well as Europe, starting with that FIB4 calculation using their age, AST, ALT, and platelet count to give kind of a down and dirty first triage of fibrosis assessment. And then depending on the results, continuing to monitor for those low risk, or sending those in an intermediate risk or high risk off for a secondary assessment, fibrosis assessment, and off to our hepatology partner. So again, big message, looking at those cardiometabolic risk factors, thinking fatty liver, and getting those patients screened. Thank you.